Okay. So moving on, started from pituitary yesterday, now moving down, now we're in the thyroids. Our objectives for today. So when it comes to thyroids, we can't forget the parathyroids. So we will discuss them first, and then we'll get to the different thyroid issues as we go through it. So parathyroid is the first one, 4 to 8 tiny glands, posterior aspect of the thyroid. They have the C cells, chief cells, that secrete the parathyroid hormone. When it comes to hypo and hyperparathyroidism, when you're studying this section, the problems and the signs and symptoms that they have are all due to calcium issues from the parathyroid hormone problem. So it's like when you have high growth hormone or high cortisol, the high cortisol itself is causing the problems. With parathyroid hormone being high or low, the hormone itself is not causing the problems. The problems are coming in from the calcium issues that happen as we go through them. PTH is stimulated by hypocalcemia, so low calcium in the blood. PTH comes out. PTH will start breaking down our bone, which dumps calcium and phosphate into the bloodstream. So hypocalcemia and hypomagnesia both will stimulate parathyroid gland to increase PTH secretion. PTH will have an effect on the bone, breaks down the bone, will start dumping calcium and phosphate into the bloodstream. It's also going to affect the kidneys and the liver to start activating that vitamin D to help with calcium absorption by the intestines. So everything we're doing is to get calcium to go up in the blood. But what also comes out when you break down the bone? Besides calcium, phosphate. We don't want the phosphate. So the phosphate will get removed by the kidneys. So it increases phosphate secretion in the urine. So it gets out that way. So we don't get high phosphate. We want the calcium. So the goal, increase calcium blood levels, dumps calcium and phosphate into the mix, calcium resorption by the kidney, vitamin D activation, and then obviously this phosphaturia, so we can dump it out. There are 2 ways to classify hyperparathyroidism. So too much parathyroid, primary and our secondary causes. Primary, unregulated overproduction of parathyroid hormone. We're just producing too much of it. It gets dumped out into the bloodstream all the times. That is a primary problem because the parathyroid gland is just pumping out so much hormone. The other one is our secondary hyperparathyroidism. And this is overproduction of PTH due to a chronic abnormal stimulus. For example, chronic renal failure and vitamin D deficiencies. Those 2 underlying causes will cause your PTH to go up. Once you solve the underlying issue, PTH should come back down again. That's a secondary cause for the PTH to go up. Not a primary cause, it's a secondary. Something underlying is causing that PTH to go up. So hyperparathyroidism, 85% is just caused by one single adenoma of your parathyroid gland. The remaining have multiple glands involved. But that normal feedback with extracellular calcium seems to be lost. So once the calcium goes into normal ranges, the stimulus for PTH should shut off, but it's not. They're not responding to the calcium like they should. So they just keep on going, pumping out more and more PTH. So this chronic PTH is going to result in osteopenia. You're degrading the bone. You're pulling pieces of the bone away. You're demineralizing it, pulling out the calcium and the phosphate. So you start seeing some changes on X-ray. Resorption of the distal phalanges, tapering of the distal clavicles, salt and pepper appearance of the skull. And I'll show you a picture of that. Not very common today. But because of all this extra calcium floating around, going to have to get taken out by the kidneys. You're going to get risk of calcium stones, renal stones now, made of the calcium, because all the excess calcium in the blood making its way through the kidneys, it can precipitate out, and you get your calcium oxalate crystals. So this is what it's called osteitis fibrosa cystica, and you can see like the salt and pepper appearance of the skull. It's not bright white, and you can see some demineralization, in these pictures here and up there as well, because the bone's being resorbed because of all this excess chronic PTH secretion going on. And here's another one, the salt and pepper appearance of the skull. Okay, just from bone being resorbed due to chronic PTH. So the other symptoms of the hyperparathyroidism is all due to the hypercalcemia itself, not due to the hyperparathyroidism. So what is high calcium? What does it do to us? Muscle weakness, fatigue, volume depletion, some serious cases, coma and death. You get some neuropsych manifestations, some depression, confusion, and then also this increased calcium can also cause gastric acid secretion, so they may get some acid reflux as well. But again, all of these symptoms, high calcium. So who's at risk for this hyperparathyroidism? Mean age in the 50s, women higher ratio than male, and also a history of neck or irradiation or neck surgery. So we mentioned this in the past. If you ever work in a cath lab or the fluoro rooms, you wear the lead. A lot of them also have a neck collar to protect the thyroid and the parathyroid from the irradiation from doing all that. Signs and symptoms, bone pain, you're resorbing the bone. Kidney stones, all the excess calcium can precipitate, causing the stones. Our mental changes, maybe some GI upset. This is important as well. Shortened QT interval, prolonged PR interval. You'll see this on EKG. I have a picture for you in a second. Obviously, hypercalcemia, because PTH is going up, so calcium will go up as well. Anemia, our vitamin D deficiency eventually, and PTH will be elevated. Labs, calcium will be high, phosphate low because our kidneys are getting rid of it. Urine phosphate is going to be high because hyperparathyroidism, the PTH is going to cause all that phosphate to leave into the urine. Serum alkaline phosphatase is going to go up if they have the bone problem where it's resorbing the bone. Alkaline phosphatase is one of the enzymes in the bone matrix, and it comes out when you start degrading the bone. So that will go up as part of the bone degradation. Vitamin D, obviously serum PTH goes up, and you can do a 24-hour urine on them as well to see those levels over 24 hours. As you go through the lab, just understand why it will go up, what makes it go down, just due to the hormone levels, and it makes sense from there. Diagnostic studies for hyperparathyroidism, EKG. We talked about what you're going to see on the EKG. X-rays are not required, but they may show some cysts, the skull modeling, that salt and pepper appearance on the skull, some osteosclerosis or vertebral bodies. Do a DEXA to see how the bone mineral density is doing, see the risk of fractures. So here is your prolonged PR interval and our shortened QT. So prolonged PR, shortened QT are seen with hypercalcemia. And so when you're studying, if you're talking about hypoparathyroidism, the symptoms are the opposite. We'll get to that in a second. So essentials of diagnosis, elevated PTH, high calcium is usually going to be, yes, you have hyperparathyroidism. This last thing in orange is kind of like the mnemonic to remember the symptoms of hyperparathyroidism: bones, stones, abdominal groans, psychic moans with fatigue overtones. So all the different things. that hyperparathyroid patients have. So again, just reviewing the signs and symptoms that your patients will have, going to affect nervous, digestive, musculoskeletal, and obviously the urinary symptoms. Complications, UTIs, renal stones, obviously obstruction, long bone fractures. Those are not very common. They're going to be pathologic. So doing weird activities will cause them to just shatter for no reason. Arrhythmias due to the calcium disturbances and high blood pressure. Treatment and management. If they're asymptomatic, no treatment is needed. If they are symptomatic, you can just do the surgery and just remove that parathyroid gland that's causing the problem if it's diseased. And there's our infamous go to ENT or endo. If you go on that ENT rotation, and you guys had a little clinical spiel with Dr. Sales yesterday, the ENT surgery, parathyroid, those are some of the things that you'll be doing there. Saline for dehydration, and give them some vitamin D because of the deficiency they're going to have. That's basically it for that part. Other things, we have to take care of the decreased bone density now. So we give those bisphosphonates, calcium mimetics, Sensipar. These are all things that kind of make the parathyroid more sensitive to calcium, so it shuts off the parathyroid hormone, and bisphosphonates are going to help with your bone mineral density to get that up again. So for monitoring, if they're asymptomatic and they don't have surgery, every 6 months, check their calcium and creatinine levels and get an annual bone mineral density. These are asymptomatic patients. But what are their symptoms going to be? The bones, moans, groans, fatigue, all those overtones, all those things. Those are the symptoms that mean they're not controlled. Most clinicians will advocate for surgical therapy in all patients with primary hyperparathyroidism. Why not secondary? Because the parathyroid is not the problem in secondary. It's an underlying cause. Treat the renal failure and whatnot. There you go. Okay. That's hyperparathyroid. Now moving on to low insufficient parathyroid hormone. The absence of adequate PTH activity, ionized calcium concentration will fall, and they're going to get hypocalcemia. Primary hypoparathyroidism is usually iatrogenic causes of some underlying diseases. They're going to be variably symptomatic. Your history of these patients, talk about signs and symptoms of neuromuscular irritability. Why are they going to get irritable? What's missing? Calcium. There's no more calcium. We're losing it because of the low parathyroid. So again, these signs and symptoms are from hypocalcemia, low calcium. Paresthesias is a big one. We'll talk about that in a little bit. Hyperirritability, fatigue, mood swings, seizures. If they already have a history of epilepsy, they may have hoarseness in the voice, wheezing and dyspnea if they have bronchospasm, muscle cramps, and whatnot. Again, neuromuscular irritability, the things that we normally do won't happen the right way, causes problems. Physical findings, muscle cramps are going to be common. Tetany can develop if hypocalcemia is severe enough. They get tetany. So be careful with the laryngospasms, bronchospasms, to cut off their airway. And now you have to worry about intubating that patient because the airway closed up. So be very careful with tetany. So we can do a couple of signs for these patients to see their irritability. One is called Chopstick sign. Facial twitching. We talked about before, one of the signs of this is muscle twitching, especially around the mouth. So we can elicit that with called Chopstick sign. You gently tap the facial nerve and that side of the face will twitch a little bit. The mouth will twitch. And this goes up towards the ear. So that's Chopstick sign. Tap the facial nerve and you'll see the mouth twitch. The other one is Trousseau sign. This is a carpal spasm. This is when you you blow up a blood pressure cuff and you get rid of the pulse of the radial artery for that arm. Keep it up for, a few minutes, and you'll start seeing a carpal spasm happening. That is a sign of hypocalcemia, positive sign for having hypocalcemia. Then you got to figure out why, a cause, probably hypoparathyroidism. So risk factors for hypoparathyroidism, most common cause is that. Why? They take everything out. So if any of your patients says on a surgery, hey, have you had surgery? And they said, yes, I have my thyroid taken out. What should be your next question? Do you still have your parathyroid glands there? Sometimes they leave them in, sometimes they'll move them to like the forearm or put them somewhere else. But do they still have the parathyroid glands? Neck surgery, trauma, neck malignancies. These are two weird ones, Wilson's disease and hemochromatosis. Can also be a risk factor for hypoparathyroidism. Signs and symptoms, again, just repeating a lot of them. We talked about that neuromuscular irritability. Here's our chopstick sign, Trousseau's, the carpal spasm, a lot of the tingling, personality changes, nails become brittle, vision problems, dry, scaly skin. DTRs become hyperactive with this as well. So this is all signs of hypoparathyroidism. Labs and imaging. Again, serum calcium and magnesium are going to be low because nothing is stimulating it to go high. They're not responding. Serum alkaline phosphate is going to be normal because we're not breaking down the bone. There's no reason for it to be around and go anywhere. Obviously, PTH being low. So like on your exam, there's going to be a lot of labs on this one. But you will have obviously the reference sheet there to look at your normals. But if you see a lab and a PTH is low, that's probably the answer, hypoparathyroidism, because there's no other reason it would be low besides that. Phosphate, why is serum phosphate potentially going to be high? What don't we have? What hormone are we deficient in this whole segment? PTH. What does PTH do for phosphate? Gets it out in the what? Urine. So if we're not doing that anymore, the phosphate's going to stay and get stuck where? In the blood. And that's why serum phosphate may be high, because the PTH isn't there to get rid of it into the urine. So it may build up a little bit. Urine calcium will be low. Makes sense. If it's low in the blood, it's going to be low in the urine probably. Radiographs, increased bone density and cutaneous calcifications. What happens is all this calcium just gets dumped into the bone. The bones become harder and thicker. I'll show you some pictures of what happens in a second. CT of the skull, you may see some calcification of the basal ganglia. EKG, prolonged QT interval, and some T-wave abnormalities with this one. So here's our prolonged QT interval. And this one doesn't really show any T-wave changes, but you may see some as well. But prolonged QT. So whenever you're looking at your prolonged QT intervals, there's certain medicines and things that will cause a prolonged QT. Now you can add this to your list of differentials for a long QT. So here are the cutaneous calcifications. All this calcium gets dumped into the bones, and we start seeing these deposits of all the excess calcium. It's not in the blood, it's going into the bone. And then here are some of these tophi. These are calcium deposits on the skull, which then obviously show up on this scalp. So essentials for this one: tetany, tingling of the lips and hands, psych changes, positive chopstick sign and Trousseau's, and then your labs from there. Calcium and vitamin D are the mainstays of treatment. You guys got to give them calcium. So calcium supplements like Oscal, Tums, Citracal, give them some vitamin D as well. If they undergo parathyroidectomy due to parathyroid hyperplasia, they may have hypoparathyroid later. And then here at the bottom, there's an auto transplant of the parathyroid gland. And again, they usually put it in the forearm or the neck. But the parathyroid gland can go anywhere as long as it has access to the blood and it can sense what's going on. Complications of hypoparathyroidism. Again, these are all like untreated, long-term, you're not taking care of these patients. Neuromuscular problems, they can get cataracts from this. Hypothyroidism may develop later on. Some Parkinsonian symptoms may develop. Some permanent mental damage as well. They are at a lifelong risk of symptomatic tetany due to this low calcium. So without access to calcium, the patient may die. So the patient education is very important. They have to take the calcium. Here's a cataract due to hypoparathyroidism. Treatment if they have an acute tetany attack. So now they're coming into the ED, they're tetany, they're having problems breathing. So always first get that airway under control. Then we need to give them calcium. So we give them calcium gluconate IV will help. You don't need to know all the different ways we give it. Just know IV calcium gluconate for tetany. And give some mag sulfate as well. And then wean them over to oral when they can tolerate it. You start off with the IV to get them going, and then you wean them off to the oral before they go home. So talk to your patients about complications, importance of periodic labs. You don't want to lose these patients to follow up. They need routine labs. Make sure their calcium levels are okay. Make sure they understand the different signs and symptoms of over and under treatment. How would they know the signs and symptoms? What are you going to tell them? What are they, like, just basically problems with calcium? High calcium or low calcium, what are they going to have? Any tongue tingling around their lips, the paresthesias, stuff like that. Make sure they're aware, both directions, hypocalcemia and hyper, because what if they just take too many calcium tablets? Now their calcium levels go up. And the last thing here is make sure they wear a bracelet that tells whoever medical providers this patient has primary hypoparathyroidism, and therefore will know they need to get IV calcium as probably part of their treatment if they come in with some altered mental status. Any questions about the parathyroid gland? We didn't really do much with it in ClinPath because it really wasn't there. Just these are only two things really with it. So when you're studying, again, too much parathyroid and then too little. Moving on now to our thyroid glands. So we'll first deal with hyperthyroidism first. These are the normal values. Again, you are going to have your lab value sheet on your exams. You don't need to memorize all these. But remember, the F in the front is referring to the free version of that molecule, of the hormone. So we have free T3 and we have free T4 and we have bound T3 and bound T4. Why is knowing the free levels important as well? It's what's available to be used. If it's bound to the protein, the thyroid hormone is inactive. It doesn't do anything. So when we look at the T4 levels, we're looking at all of it. We don't know how much is bound. So by getting the free levels, we know how much is actually free around to have an effect on the body. You can hear about the thyroid kind of controls everything in the body. So if your thyroid's pissed, you're going to be pissed. Essential to diagnosis: sweating, irritability, fatigue, palpitations and anxiety, loose stools, diarrhea, heat intolerance. So you just get hot very easily, start sweating a lot. Warm, moist skin, tachycardic, tremors. And our labs, TSH is going to be low and our thyroid hormones are going to be very high. We have hyperthyroidism and something is turning it on. So hyperthyroidism is also known as thyrotoxicosis. Risk factors: positive family history, female. Other autoimmune disorders, we'll deal with that on Thursday. And then iodine repletion after iodine deprivation. They weren't given iodine, but they never repleted it. They're short iodine. or they have too much iodine they're giving it. So signs and symptoms, we just went over that before. This is important as well. Any elderly patient who comes in with new onset of atrial fibrillation, check the thyroid levels. The thyroid being, if they're hyperthyroid, that can cause them to go into atrial fibrillation. They don't have an actual like cardiac cause for it. It's an underlying cause that put them into AFib. Labs, TSH very low. T4, T3 are going to be high. You can check CBC, make sure they're not anemic. Check your renal function, LFTs, and your electrolytes. Further labs are antibodies. If they have TSH-RAB or this TRAB, you may see it written both ways. These are the antibodies to the TSH receptor, and that is Graves' disease. So on your exam, if I say that their labs are positive for TSH-RAB or TRAB, it's hyperthyroidism, it's Graves' disease. If they have presence of thyroperoxidase, TPO, or thyroglobulin antibodies, that is going to be Hashimoto's disease. Thyroid peroxidase is the enzyme that's needed to make your thyroid hormones. So if you don't have that, you can't make as much, or you can't make as much thyroid hormones. Thyroglobulin is the binding protein. So if you don't have that, you're gonna have problems as well. Hashimoto's, you'll see later on when you talk about it, it starts off as hyperthyroid and then eventually will burn itself out and turn into hypothyroid. Thyroid scan, well, EKG may show AFib depending on the age. Thyroid scan, controversial, but you may want to rule out any toxic nodules. If on your palpation you feel something irregular, rubbery borders, uneven on one side versus the other, or they actually have, visible nodules that you can see on the throat. Ultrasound with fine needle aspiration of the nodule, done by Endo or ENT. Put a needle into the actual nodule itself, pull cells out, and they're going to see what those cells are to see if it's cancer or not, what's doing. Some prescriptions that may alter labs, estrogens, heparin. Here's our amiodarone. Remember amiodarone, LFTs, and thyroid. Those are the big ones you're going to hit with amiodarone. Phenytoin, rifampin, salicylates. What are those? Aspirin. Got to be careful with aspirin if they're in, we'll talk about that in a little bit with thyroid storm. So here's your thyroid scan. Again, these are looking at uptake of a radioactive iodine that we inject back into the person's body, and we see where that iodine goes and it glows. Obviously, Graves' disease, hyperactive thyroid. Both sides are equally lit up. This is a normal, like, hypertrophy of the thyroid gland, but it's even on both sides. Then you can see in the bottom here, this toxic multinodular goiter, multi-nodules, and our toxic adenoma is one big hot spot right there. So some differentials for hyperthyroidism. Remember, they're going to come in with sweating, tachycardia. So that could be a bunch of different things. We don't know what that is when they first come in. So anxiety, it could be a malignancy. Diabetes, especially if you have a hypo event, you get tachy, sweaty, irritable. Pregnancy, menopause. Here's our pheochromocytoma. That could also have some, effect on the thyroid. Complications, sinus tach. Here's our AFib. Exophthalmos is the bulging of the eyes. You get the accumulation of proteins behind the eye and it pushes it out. Hypokalemia, hypercalcemia are here. Goiter, maybe here as well. Some fertility issues. And the last thing is the bad one, this thyroid storm or thyroid crisis we'll talk about in a second. Treatment for just regular old hyperthyroidism, endo or ENT if they're having any type of swallowing problems from the large thyroid, possible surgery, anti-thyroid medications. There are two of them, methimazole and propylthiouracil, PTU. The only two. The really big thing you got to know is that PTU is a drug of choice if they're pregnant. So if they're pregnant coming in with hyperthyroidism, you have to treat it. You have to give PTU. You can't give methimazole if they're pregnant. And you can also do thyroid ablation with iodine 131. But if you ablate the thyroid, you can eventually cause hypothyroidism because you basically burnt out the thyroid. So methimazole is a drug of choice, except when they're pregnant. Therefore, just if they're pregnant or any risk or they want to become pregnant, just start the PTU. The only real difference is methimazole is more potent and longer duration, so it's only like a once-a-day dose. The PTU, because it doesn't have the same type of profile, you have to take it more than once a day. Some patients don't want to take more than one pill a day. It's a compliance issue, but they're pregnant, so they need to take the PTU. In the United States, the most common definitive therapy for hyperthyroidism is ablation of the thyroid with oral dose of radioactive iodine. Some patients, if they have a toxic multinodular goiter or toxic adenoma, they get that radioactive iodine immediately. You gotta stop that growth from happening. Patients who have autoimmune Graves' disease can be treated for 12 to 18 months because sometimes they may go into a remission. So you kind of just, instead of doing surgery so fast or irradiating it, you kind of just wait and see. Yes? I would just think of it as put them on PTU anyway. Okay. So Graves' disease, the most common cause of hyperthyroidism, autoimmune disorder, attacks the TSH, has those antibodies, and it turns the thyroid gland on. More females than males, 8-to-1 ratio, 20 to 40. Some other signs, they may have Graves' exophthalmos, that accumulation of protein behind the eye, and it makes it bulge out. Pretibial myxedema is that orange peel texture on the anterior part of the shin. And they may have some pernicious anemia, myasthenia gravis, and diabetes possibly as well. And this is what happens. Here's our antibody receptor, and it just stimulates the thyroid gland, and it turns it on, and it keeps pumping out more and more thyroid hormone. Here's the pretibial myxedema and what it looks like, the orange peel texture on the shin. Here's exophthalmos, goiter, and then more of that pretibial myxedema. Treatment, go to Endo. It's always going to be there. But you can also start propranolol, 20 milligrams daily. Help with those tachycardic symptoms, bring everything down, kind of suppress the sympathetic nervous system, which is being overloaded with the hyperthyroidism. And then you give them the thiourea drugs. These are the anti-thyroid drugs, methimazole and PTU. Again, just remember PTU if they're pregnant. Otherwise, just give them methimazole. Radioactive iodine, never during pregnancy. And their option is thyroid surgery to remove the excess tissue. If you have less tissue, less thyroid hormone being created. So this is the bad part about having very, very high levels of thyroid hormone, is this thyroid storm or thyroid crisis. It's an extreme form of thyroid toxicosis. It's a medical emergency with a very high mortality rate. Basically, you're having a huge dump of thyroid hormone all at once into the body. And that big dump of thyroid hormone obviously causes your metabolism to go crazy. So signs and symptoms, marked delirium, severe tachycardia. If they have a defibrillator in place, the defibrillator may go off multiple times because Normally, defibrillators, when they shock you, it's supposed to go your heart rhythm back into a normal rhythm. But in this case, the heart isn't the cause of the problem. The cause is the thyroid. So even though the machine's going to shock you, the thyroid hormone is still floating around. So your heart rate is still going to be fast, and it may shock them again. It may shock them again. So if you see stuff like that, think thyroid storm, check the thyroid out. Some GI distress, vomiting, diarrhea, very high fever, and hypertension as well. So it's a medical emergency. We have to treat it fast. Hypertension may be followed, all that extra hypertension, may get heart failure later on, and they may get some hypotension and shock afterwards. The adult mortality rate is 90% if diagnosis is not made and the patient is left untreated. Better control of thyroid toxicosis, early management of the disease, rates will decline to 20% if you catch it early enough. Most often seen in a thyroid toxic patient, so they already have hyperthyroidism. Normal patients who don't have any history of hyperthyroidism should not be going into a thyroid storm. It's usually the thyroid toxic patient. While they're having the event or something that precipitated the event, illness, trauma, or emergent surgery can cause them to go into a thyroid storm. So precipitants, your infection, non-compliance with your anti-thyroid medication. The medicine is supposed to keep the thyroid levels at bay. You stop taking it, they start rising immediately, put you in a thyroid storm. Recent trauma, MI, stroke, DKA, or hypoglycemia can also do it as well. Childbirth, PE, drugs can do it. Overdose of thyroid hormone tablets. You just take a lot all at once. You're gonna, all that thyroid hormone is gonna get dumped into the system, can cause problems. And recent thyroid surgery. Yes. I don't know if it's like a DKA type 1 type of deal. I don't think they just show up with thyroid storm. They have to have one of these. They already have to have the system ready for the high thyroid hormone. No, I don't think they show up in thyroid storm for the first time they're ever being diagnosed with hyperthyroidism. Because usually they're going to have signs of like, so because of hyperthyroidism, especially 8-to-1 women, any woman coming in 20s with, sweating, they're eating like crazy, but not gaining any weight. Those are the signs of hyperthyroidism. We're going to do a thyroid panel anyway, and we'll find out before this even happens, usually. So if they have thyroid storm and they come into the ED, they go to the ICU, correct that hyperthyroid state. So you give them those anti-thyroid hormones. High dose PTU is preferred in this case because early onset, and it inhibits peripheral conversion of T4 to T3. Why is that important? We're not making the active thyroid hormone. Remember, T3 is the more biologically active form. T4 gets converted to T3 in the periphery to make more of the active one. We don't want more active ones, so PTU is very good in this case because it stops that conversion. Don't need to know about all the dosing. That's what you give. PTU, why? Early onset of action and inhibits conversion. So we administer iodine compounds, leucoiodine, potassium iodide. It helps block the release of TSH. Radioactive iodine is not effective in thyroid storm. If they're hyperthyroid, but they're stable, you can do the irradiation and ablate the thyroid. It's not going to act fast enough in this case. That's why it's not a therapy. It's too slow. Propranolol for that sympathetic nervous system blocking, get the tachycardia down. Hydrocortisone, give them some cortisol. And DC all aspirin. So here's our salicylates. This is where you want to be careful with aspirin and thyroid storm. Stop it because it displaces T4 from the thyroid binding globulin. Remember, if it's bound to the globulin, bound to the protein, it's inactive. It's not going to work. So if aspirin's displacing that T4 bound, now it's free T4. Now it can be converted to T3, and you're making the thyroid storm worse. So that's why you stop the aspirin. Once the acute phase is over, you kind of stop all those iodine preps, as long as they become afebrile and their status goes back to normal. Wean off those glucocorticoids, the prednisone, wean them off. And then those PTU or methimazole, just titrate it to maintain normal thyroid function. And what lab do we look at to know our normal thyroid function? Look at your TSH. If your TSH is within normal levels, then we're okay. If it's too high, we need to give you more of the methimazole. If it's too low, we need to back off on it. But we go by the TSH level. Yes, you will check T3, T4, all that stuff, but the TSH is what we look at. Beta blocker may be discontinued once the thyroid function normalizes. They'll be okay again. You can stop those propranolols. We'll do Hashimoto's and we'll take a break. So Hashimoto's is a transient autoimmune hyperthyroid, hypothyroid. It's what starts off as hyper, and then gradually it goes to a hypothyroid state. What's happening is CD8-mediated follicular cell destruction. So again, autoimmune, we're attacking ourselves, we're destroying the cells. We also have anti-TSH receptor antibodies, and these antibodies will block TSH action versus stimulate it like the Graves one does. So anti-TSH receptor antibodies, these shut it off. TSH receptor antibody without the anti will turn it on. So make sure when you're studying, don't confuse the two different types. We also have anti-thyroid peroxidase antibodies. So TPO, we needed to synthesize it. If we block it, we're not going to synthesize any T3, T4. Anti-thyroglobulin antibody, we're going to block the storage protein. Therefore, we're not going to have enough thyroid going around. This is common in postpartum patients. Also have an increased risk of papillary thyroid cancer with Hashimoto's thyroiditis. So essential to diagnosis for Hashimoto's, swelling of the thyroid gland, they may have a goiter, and anti-TPO and the anti-TG antibodies are going to be elevated. So anti-TPO and the anti-TG. Risk factors, female to male, 6 times more females will have Hashimoto's. There's autoimmune, so there's a family history here. Drugs, amiodarone can cause hypothyroidism over time, Hashimoto's. And again, your beam radiation, if you're not wearing that collar, excess radiation, whatnot. These are the risk factors for it. Signs and symptoms, enlarged, firm, finely nodular thyroid. When it comes to the thyroid, it's very important to differentiate. Are they painful lesions, painful masses? Are they non-tender? Are they firm, rubbery? Or are they loose and mobile? So these are very important things to start picking up when it comes to like different types of thyroid problems. Asymmetrically enlarged thyroid. So like one lobe will get enlarged versus the other one will. Mild dry mouth, dry eyes. At first, they are hyperthyroid, and then they become hypothyroid symptoms. So they'll have like the tachycardia, the sweating, heat intolerance, and then gradually it'll go the other way, cold intolerance, bradycardia, and cool hands. Labs and imaging, these all vary because of what stage you might be in the Hashimoto's. So remember, it starts off as high. So your TSH will be low, free T3, free T4, all that stuff will be high. And then as you go to hypothyroidism, TSH goes up and the error labs go down. Yes. I don't know how long it does take. I know it's not like, it probably takes a couple of years, maybe. It's a slow process. Your TPO, TG enzymes, the antibodies will be elevated. SED rate will be elevated. Your radioactive iodine uptake is low. The thyroid is not active. It's not going to uptake all that iodine to use it. So the uptake is slow. Ultrasound, diffuse, heterogeneous density, hypoechogenicity. So there's not going to be much inside these nodules. And then do a fine needle aspiration of any nodule via ENT to see what the cells are inside the nodule. And you can see here, this side is a lot bigger than that side is. So complications, again, almost always goes to hypo. Treatment and management, go to endo, but eventually they're going to need levothyroxine or Synthroid to replace the thyroid hormones that they're losing. So eventually just put them on Synthroid or levo. Okay, let's take a break. Come back in 10 minutes. So come back around 1:30, I guess. We'll start 1:30. Okay, we'll get started. So hyperthyroidism, too much thyroid hormone. Now move on to too little thyroid hormone. And you get the other cartoon, the bookend. So you can read that later if you want. So cold intolerance, weakness, fatigue. Just if you know one symptoms, the other thyroid is the opposite one. So don't memorize both, just memorize one. Constipation, the other one had diarrhea. Depression, hoarse of the voice. Menorrhagia, bradycardia, hyperthyroidism had tachycardia. Delayed slow DTRs, hyperthyroidism had hyperreflexive DTRs. Dry skin, anemia, hyponatremia, hyperlipidemia, low free T4, and obviously TSH will be high, trying to get the thyroid to pump out more hormone. Risk factors for hypo, increasing age, autoimmune disease, your Hashimoto's or Graves. Previous postpartum thyroiditis. And again, as always, any type of radiation to the neck are risk factors. Signs and symptoms, again, I'm not going to go through all of them. The big ones, cold intolerance, constipation, paresthesias, dry skin, Brady, hypothermia, so that cold intolerance. What else is big one? Carpal tunnel, weight gain, hyporeflexia, menorrhagia are the big ones that you'll see when they come in, complaints of hypothyroidism. It's another way of looking at it. All the different ones for hypothyroidism. You guys know the whole Winnie the Pooh, all the characters are psychological disorders? Like, yeah, they're all, each character is a different one. Like gluttony, Eeyore's depression, Rue is autism, anxiety, Piglet. Al, I think, is narcissism. They're all there. So all your labs that you pick are all the same ones you would do. They all have a reason for doing it. So I know you guys are excited about that. TSH elevated because we're trying to get the thyroid stimulated to do something. Your thyroid hormones are low because the thyroid's not doing anything. Check your kidneys and renal function, rule out anemia, check your cholesterol levels, CPK levels, AST, lactate dehydrogenase, sodium, glucose, and you don't really need radiological imaging for hypothyroidism. Not really going to show a whole lot. Here's a good summary slide with regards to the different types of hypo and hyperthyroidism as far as what the labs show. So this is a great one to star and come back to later for your tests. Some associated conditions with hypothyroidism. Obviously, our anemia is there, diabetes, rapid cycling, bipolar is here, depression, and so on and so forth. MVP is here, ischemic heart disease. These are associated with hypothyroidism. Again, untreated hypothyroidism. If you treat it, they'll be okay. Complications can be treatment-induced CHF. How does that work? What condition can result in CHF? Hyperthyroidism, but what specifically will do it? The bad one, thyroid storm, right? And when they get severe hypertension, they go into heart failure. So why in a hypothyroid patient would a complication be treatment-induced CHF? Overtaking too much medicine. They're taking too much thyroid medicine. So they're putting themselves into a hyperthyroid state by taking too much thyroid medication. That's what that is. Mixed edema, coma, similar due to low thyroid hormone, lots of infections, some psychosis can be there, rhabdo, injury to the kidneys, infertility. There is a real, yes. So a patient is hypothyroidism. So what's the treatment? What do you have to give them to treat it? So what medicine do you give them? Yeah, so you give them thyroid hormone. But what happens if they take 5 tablets at once instead of just one? The treatment of you're just taking too much Synthroid, or they're taking too much Levo by themselves, and it makes them go into the thyroid storm leading to the CHF. It's just part of the having too much thyroid due to you overdosing on thyroid medication. A lot of the guys may unfortunately have to go to this infertility OB-GYN rotation out in the coast, because guys, it's very hard to get OB rotations. But it's an infertility clinic, so it's a lot of endo, a lot of the hormone therapy. There is some link between miscarriages and thyroid hormone antibodies. So that's why there is some infertility there as well. Hypersensitivity to opiates, some heart disease, hypoventilation as well. Treatment and management, you got to get the thyroid levels back up. So you just give them thyroid hormone to reverse the clinical progression of the disease and correct any metabolic derangements. So again, we look at TSH levels to monitor treatment levels for there. Treatment of thyroid hormone can be started at anticipated full replacement doses in individuals who are young and healthy. So if you look at the dosing for these levothyroxine and Synthroid, they're like in very, very, very small micrograms, like 0.112 micrograms. They're very, very small. And the increments are very small. So you can start them on a low dose and then just check them back 3 months, see how the TSH is doing, and then you raise it from there. If they're elderly or known heart disease, just start lower than you would normally and go up from there. Adjustment no less than 4 to 6 weeks. And starting doses could be around 50 to 75 micrograms. So first line is levothyroxine. Is the generic. Synthroid is the brand name. I don't know why, but Synthroid and levothyroxine they're not matched 1-to-1. Meaning if you're taking 50 micrograms of levothyroxine and you want to switch to Synthroid, you can't just start 50 micrograms. It's not a 1-to-1. For some reason, they don't work the same way. Whereas like if you take a brand Plavix and you give generic Plavix, 75 milligrams, it's going to be the same brand versus generic. These, I don't know why, but they don't correlate the same way. So if you're switching from one to the other, you have to do some more routine blood draws. But again, you start on dose. Elderly patients start on a lower dose. Contraindications, thyrotoxic heart disease, or any uncorrected adrenal insufficiency. Some interactions with thyroid medications, oral anticoagulants. Here's your insulin and your oral hypoglycemics. So there may be some interaction there. So if they're on those medications, do more routine thyroid panel monitoring and see get the right dose. So in general, just hypothyroidism can be treated with just daily doses of levo. Clinical benefits begin 3 to 5 days and will level off after 4 to 6 weeks. Achieving that TSH level within that reference range may take months because now we're having to like redo our hypothalamic pituitary axis with this new type of medication, and dosing changes every 6 to 8 weeks until the patient's TSH is in target range. That's how you know you're treating them appropriately. You look at the TSH. And of course, ask them about their symptoms. Are they still having symptoms of the hypothyroidism, cold intolerance, brittle hair? Those things will start reversing. So patient education for hypothyroidism, medication compliance. Their thyroid function will not come back, unfortunately, that you have to let them know this is a lifelong medication they need to be on. Also talk about the adverse effects of Synthroid over-medicating. This is taking too much thyroid, self-medicating yourself. Tell your patient, be careful, don't do that. It can cause a bunch of other problems, mainly that thyroid storm is the bad one. Again, lifelong treatment. Talk about infection and heart problems, if they have anything, and those signs of thyroid toxicity, fast heart rate, high fevers, altered mental status, stuff like that. Any questions about hypothyroidism? How to diagnose it, what are the signs and symptoms, treatment, Synthroid, levo, until they get TSH in normal range. Check every 3 to 6 weeks and you're fine. Thyroid nodules can be single or multiple on your exam. You have to get a thyroid function test if you feel any nodules on your patient. You can also do a thyroid biopsy, especially any history of head, neck, or chest radiation. Do your nuclear medicine thyroid scan, and then follow up. Here's the really good thing about thyroid nodules. 95% of thyroid nodules are benign. Okay, so if you have a thyroid nodule, 95% of the time it's going to be a benign nodule. Most are asymptomatic. They may have a goiter. The hoarseness and dysphagia are just mechanical problems due to the goiter in the neck. It's a space-occupying lesion. It's going to compress your airway in your esophagus, therefore causing those things to happen. It may be hypo or hyperthyroid. Those nodules, we don't know. It could be either or depending on how active they are. And here's some examples of what you'll see if someone has a nodule or a goiter. It's very subtle, but you can pick it up the more you look at normals and whatnot. Imaging, get your thyroid panel, see what's going on there. Get your enzymes and your antibodies and see what's doing with that. Get your ultrasound with fine needle aspiration and do your radioactive iodine uptake scan. So this is a good chart to tell you what you find. Is it a low index of malignancy or a high suspicion of malignancy? If they have a history of goiter in the family, low risk of malignancy with that nodule. However, if they have any history of head, neck, breast radiation, now your suspicion for malignancy goes up because they've already been irradiated. On physical exam, soft nodule, older female, benign, low suspicion. If it's a firm nodule, lymph nodes are involved, and a young male, it's highly suspicious for malignancy, especially if it's a male. I think I showed you the picture of that one guy on the house hunting show, whatever it was. He had it, again, young male. It was cancer. He had it taken out. Fine needle aspiration biopsy. Adenomas, if that's what the result is, probably going to be malignant. However, if it's a papillary carcinoma, follicular, medullary, those are highly suspicious for malignancy. Uptake. Hot nodules are benign, low likelihood. If it's a cold nodule, high index of suspicion for malignancy. Ultrasound, a cystic lesion. This is that echogenicity. Okay, there's a hole inside because it's hollow. So it's a cystic lesion inside, it's a cyst and there's fluid inside. That's a nodule. When you have that on fine needle aspiration, low likelihood of cancer. However, if it's a solid lesion on ultrasound, then high suspicion for malignancy. And then when you give them the suppression therapy, what are the two drugs are thyroid suppression? Methimazole, PTU. So you give them those medications, the thyroid nodules decrease in size because now they're not being accentuated anymore or excited to produce more. The tissue will slow down, decrease in size, low likelihood of a malignancy. Again, that's why it's also hot, very metabolically active, making a lot more thyroid hormone. With the thyroxine suppression therapy, malignancy will continue to grow because nothing is suppressing it to stop growing. So that's why your physical exam and things that you do will tell you this high likelihood of being benign or is this malignant cancer. Treatment, endo, go to endo. Monitor on a regular basis, re-biopsy if it grows, possible surgery depending on what's going on with it. Obviously go to ENT, they'll take care of it, endo and whatnot. Patient education, really make sure they have regular follow-up. Any changes in symptoms, now they can't swallow well, problems talking, hoarse voice, come back in, get checked again, make sure the thing is not growing, getting bigger. So neoplastic diseases, painless swelling in the thyroid. Thyroid function tests are normal. These are not producing any thyroid hormones. They're just a nodule on the thyroid. It's a cancer on the thyroid. And they're going to have history of head, neck, chest radiation. And obviously a positive fine needle aspiration, the biopsy is going to be positive for cancer. So palpable, firm, non-tender nodule, cancer. Asymptomatic, neck discomfort because of the mass that's in their neck now, which obviously is going to lead to the dysphagia in the horse. Again, to understand why they're having these symptoms. Just they have an enlarged tumor, going to compress tissues. Your trachea and esophagus are right there as well. They will be compressed. Labs, imaging, solid nodule, cold on the scan, diagnostic. Because we now found cancer in the thyroid gland, we'll do a full body PET scan to see if this cancer is anywhere else in the body. So we're just going to check everything, make sure anything goes there. Treatment management, you got to get surgery and oncology involved to get this tumor removed. So you got to consult them and get them involved in the case. On the left is a normal thyroid gland removed. On the right is a cancerous one. This is actually a former student who got diagnosed during their first year, just like you guys, with thyroid cancer. Over winter break, she went and had it removed, came back to school. And then over spring break, she went back and had the final irradiation therapy to remove any lingering pieces left over. And she's doing fine. She finished PA school and she's doing good. So she sent me a picture of her thyroid for you guys. So these are the types of thyroid carcinomas. There are 4 of them. The most common is the papillary thyroid cancer. Ages are all about the same, 40s and 50s. You can see a lot of them are going to be females. However, as you get to the more anaplastic ones, you start seeing a lot more males pick up on the more severe side, on the far side. Then you look at the death rates. 6% for papillary, but look at the anaplastic one, the more severe ones, you're up to 98% for anaplastic. But again, the majority of them are going to be papillary, which is non-cancerous. But of the remaining ones that are anaplastic, 98% of the anaplastic patients will pass away, unfortunately. This is also looking at our 5-year survival rate. So with Professor Edgar with HEMONC, do you guys talk about this TMN scoring? He's actually coming back when you guys come back from spring break. He's going to give you a gyne cancer lecture. So you'll have him in a couple weeks for gyne cancers. So I'm not going to make you memorize this, but what's important here, even if you're stage 4, your 5-year survival rate with thyroid cancer is still 85%. So even the worst type of stages of thyroid cancer staging for papillary, which again, papillary is the most common one and the most benign. So these are papillary tumors. Even the worst one, any amount of tumor size, any amount of lymph node involvement, any amount of metastases, you're still going to have an 85% survival rate with thyroid cancer. So that's the big takeaway with this one. Survival rate is good with papillary thyroid cancer. Any questions about the thyroid? Okay, I've already talked to Professor Kim about starting early, so I'll tell him to come at 3. Is it 4? I can't even see the clock. 2. I can't see the clock. 2 o'clock. Okay. The clock is an hour past, I think. Okay. So 2 o'clock, we'll start. I'll let him know. See you guys on Thursday.